He was nominated 3 times for the Pulitzer Prize. So we're very fortunate to have a guest who is nationally recognized, who has been demonstrating his expertise for decades, and we can't thank you enough for making the trip, Michael. Thank you for joining us. Please give him a round of applause.
Thank you so much, Jason. I'm delighted to be here and really honored, because this is a meeting designed to accomplish something. And I'm going to talk about that in some detail, but you heard Tom talk about no censorship, so I first thought I'd share with you how I came to be a speaker here this afternoon. I was happy to come down, but first I had to talk with AIF about compensation. And they said, well, how would you like to be paid? I said, well, in the best traditions of Florida medicine, I'd like to be paid fee-for-service. That sounds fair. How we determine your fee? Well, you'll pay me based on how long I talk. And they said, well, how long are you planning on speaking? And I said, as long as you'll let me. Well, they didn't think that was fair, particularly when I added that I thought there ought to be an extra payment if I use big words, a complexity add-on, or as I called it in technical terms, implementation of a multi-syllabic vocabulary intervention. Well, they said, okay, but before we agree to that, we need to talk to some of the health insurance companies that are our members. So they went and they talked to the health insurance companies, and they came back and said, well, that's okay, he can do that, but we have to have an utterance management person take care of him, a UM manager. And it turns out the utterance management people are some of the most distinguished graduates of English as a Second Language program in the state. And it was their job to make sure that the words I used were the right words, and they would approve only those words, and after that the payment would be based on the UM approval process. Well, I didn't think that sounded like much of a good deal, so we decided finally to go to some of the government members and figure out how I ought to be paid. So what we decided was I'd come down, I'd make a speech, try to meet your needs the best way possible, everybody would applaud. 6 months later, I get a letter from a bureaucrat in Tallahassee that tells me that the payment has been denied, the speech was inappropriate, and I'm not being paid anything at all. And they called this the Medicare method. So with that caveat, I'm delighted to be here. And even though it's easy to make fun of government, the fact is what this meeting is about is having government and the private sector, the payers, and by the way, I come from working for an HR firm, so we know that the payers refers to the employers and the health plans and those who provide care to come together and reach a solution. And the solution is not a technical one, it's a political one, it's an economic one, to have frankly, the guts to go through and make the changes that we know need to be made. So with that background, this is the required healthcare crisis that every single meeting on healthcare has. And what's important is not the actual numbers, of course. It's the shape of the curve, which, as you can see, is going up, up, up. The other thing that is important is the quote about healthcare bankrupting the country. Not because it's true, which it is, but because it's not made by a healthcare person. It's the former Comptroller General, head of the GAO. When we who are in healthcare get to a point where we are endangering the economic health of everybody else in the country, of people who don't want to think about healthcare, that's what makes something truly important and truly a crisis and truly a point where we have to do something. Now, speaking of crisis, Richard Nixon was the first president to use the term healthcare crisis in 1971. Every other president since. And you have to ask yourself, if Soviet missiles or Russian missiles were still off the coast of Florida in Cuba since 1962, would we really still call that the Cuban healthcare crisis? Can you really have a crisis that's gone on for this many years? Well, of course you can't. And so you have to ask yourself, when people at healthcare meetings talk every single year about a healthcare crisis, is it really a crisis? And the answer is that the reason the healthcare system has not collapsed is at certain points along the way there, it has been a genuine crisis. And folks have gotten together, often in a bipartisan way, and certainly with the backing of the business community, and done something. They have radically changed the payment system, as President Reagan and the Democratic Congress did with prospective payment. They have changed the laws. They have changed all sorts of ways in which healthcare system is organized to stave off a true crisis. And what I'm going to talk about today is that we are indeed coming to a true crisis. That you have to be skeptical of the language and the rhetoric, we can't afford it and this, that, and the other thing. But what I want to tell you is why, in fact, we cannot afford it anymore, what has changed, what is different, and what we can do about it. It is, in fact, a truth and consequences kind of talk that I'd like to talk about today. And I promise, as Tom said, I promise to try to offend everyone. So this, of course, is an actual crisis. Right? That's a crisis. Hurricane coming, Wilma, going to be there, board up the place. When this happens, you don't have forums, educational forums on hurricanes. You do something. So let's talk about it within that context. So hurricane healthcare approaches. What are the three factors that are different? And I call it cash, computers, and culture. Why should you pay attention this time if you have better things to do with your life than to think about the incredible task of controlling healthcare costs and changing our system? Why must we pay attention? Well, the first is the economy has changed. The United States, for many, many years, dominated the world economy. And while we are still the strongest economy in the world, as you know well, we no longer dominate it. What that means is that our high healthcare costs make us economically uncompetitive in the world, and as a result, cause us to lose jobs. And so, it's not simply that prices go up here, nor is it that a Chinese hospital is going to come to Orlando and compete with the local hospital system. It's simply that if the prices get too high, people quietly move jobs elsewhere. And you know what? No matter how powerful and rich you are as a healthcare system, you cannot survive without good private sector jobs. Go to Cleveland and ask the Cleveland Clinic whether the health of the Cleveland metropolitan area is one reason why they've opened up Cleveland clinics all over the world. If you want to be economically healthy, you have to have the private sector jobs, and we simply cannot ignore our healthcare costs anymore. Sorry. The second thing is technology. The truth is that you can't hide why the costs are high anymore because we have the computer technology to analyze why the costs are high, to see what's being done, why it's being done, and on the flip side, we have the technology to enable you to improve if you're a healthcare provider. We have the point-of-care decision support to help you deliver effective care. We have the internet sites to help the consumer see whether they're getting value for the money. Transparency, whether you like it or not, is coming to healthcare, and that changes the game. Lastly is the culture, the expectations. We'll talk some about the Affordable Care Act, the legislation that dares not speak its name in Florida. But we have new legislation, new regulations, and new public expectations. And frankly, what the public expects from healthcare, the dirty little secret, what those of us who are in healthcare expect when we need treatment, has changed, and changed radically. Turmoil is opportunity. healthcare is in a period of change that frankly has not happened in this way, to this degree, since the passage of Medicare and Medicaid, which I am pretty sure nobody here in this room remembers, at least professionally. That's the level of turmoil we're at. That's the level of fundamental change. And the question is, how will we shape it? And again, that's really why I'm excited to be here, because the folks in this room are smart and accomplished. How will you shape that change for your community? This is your professional opportunity to do something significant. Well, let's talk about the economics for a moment. That chart that I started off showing with all those lines, that's the big deal chart about healthcare costs that's sort of at the 30,000-foot level. This is the one that counts. The growth of healthcare costs and insurance premiums versus individual paychecks versus the inflation rate. And you can also see what's happened to premiums in Florida. My paycheck is being hurt by your costs. That makes it personal. My paycheck and my schools. You know, what's happened with Medicaid costs that you've seen, where Medicaid is directly taking away money from education. Or to put it differently, rather than investing in our kids, we are paying for sickness. That is terribly, terribly dangerous to us as a society. You have seen here in Florida, where Medicaid has recently gone to just over 30% of the budget. It's not that that's unsustainable. I'm not sure what the limit is. It's what it does to us as a society. It's how it weakens us as a society. It's how it weakens us for the future. We know that. It's our future. That's the issue. And what makes it worse is it's your unnecessary costs, my paychecks, my schools. Now, this is from the Institute of Medicine. Care that is delivered is often not important. Care that is important is often not delivered. The Institute of Medicine has a wonderful name, and most people have no idea who they are. They kind of sound like NIH. You know, the Institute of Medicine, they've got to be important. They're kind of a private group affiliated with the National Academy of Sciences. What's important is that this is a documentation of waste in healthcare that comes from the best and brightest minds within healthcare itself. In other words, we're not arguing anymore about there being a huge amount of waste. We're not arguing whether it's people who are critics of the healthcare system and have a political agenda. None of that is on the table anymore. It is an apolitical agenda. It is a factual piece of evidence. It is from the best and brightest minds within healthcare itself. And now the question is, and what makes this fun for you all, is what can we do with political and economic skill to do something about this, to act on it? So did I mention profits and jobs? Let's just take this again down to the microeconomic level. This is showing potentially avoidable complications, 50 cents out of every chronic care dollar, and what that means when you look at just one large employer. This is a hidden tax. It's a hidden tax on business. And what it does is it takes away money that could be invested in the business. It takes away money from the average worker's paycheck. It takes away money that could be there to cut your prices to compete globally. It weakens us as an economy. It weakens us as a country, and there's no reason for it. It's waste. There is no reason we can't do something about it. So I decided to do a little math on Florida. It's simple math. So how much money do we spend every year on health care? $2.8 trillion in this country. $1 trillion is 2,800 billion, is 2.8 trillion. The percentage of the national health care expenditures accounted for by Florida, 6.3%. So that gives you $176.4 billion. Well, 30% waste, $52.9 billion. $52.9 billion. If memory serves, what's the entire state budget here? $70 billion. An extra $53 billion could come in handy? $52.9 billion. Now, that makes an assumption. And the assumption is that the amount of health care delivered in Florida that is waste is exactly the same as the national average. So let's think about that. Is Florida more or less likely to be wasteful than the national average? Fraud. South Florida's ground zero, the FBI. Unnecessary services. Miami had the highest rate of unnecessary repeat testing in 3 of 6 testing categories. That just was in an article a few weeks ago. Misprevention opportunities ranks number 34. Prices that are too high. Not there either. I'm not sure about excessive administration costs or inefficiently delivered services, but I suspect if the state culture holds, you are not below average there either. So, do we think that Florida has more or less than $59 billion of waste that you could attack? Now, I understand that that's a total pool, and some of that is Medicare, and it's not all private and all the rest. You make whatever assumptions you want. Make whatever assumptions you want on the percentage of that could go to private sector businesses or the state budget or people's pocketbooks. And you still come up with a lot of money. And as I know, Tom and Jason have heard the famous saying from former Senator Everett Dirksen, $1 billion here, $1 billion there, and soon you're talking about real money. That's what we're talking about. We're talking about real money. We're talking about dollars we know are there. This isn't theoretical. We know that money is there. So now, what do we do about it if we want to capture that money for ourselves? Well, this is also one of my favorite slides. This is a little graph that shows the relationship between what you pay and how likely you are to die. And as you can see, you can pay a lot of money and have a really high likelihood of dying, or you can pay little money at your hospital and have a low likelihood of dying. And so BMW and Mercedes-Benz prices do not guarantee you BMW and Mercedes-Benz care. And so pricing is not a proxy for quality of care. Quality will show you quality of care. Measurement will show you quality of care. Value means getting value for your dollar. There are no refunds, although Geisinger Clinic in Pennsylvania has started a guarantee policy on certain surgeries, where they guarantee that the price will cover all complications within a 90-day period. All complications included. You might think about that the next time you pay for hospital care. So, this clearly is how people in Florida get away from hurricanes. Did not seem to me very efficient, but... So what do? Well, you fight or you flee. And the fact is the businesses that decide to leave your state, or the business that decides not to hire people, they don't put out a press release. They simply don't do it. So it's up to you to fight for more efficient, more effective health care, to keep people from fleeing, to keep your community being what you want your community to be. Well, fight back strategy number 1 is better health. And you heard Jason talk about helping prevent diabetes. It is absolutely true that the best strategy for lowering healthcare costs is better health, right? Better schools, better health, better eating, all those kinds of prevention things that you hear about. And That's a different speech. Because what this is about is controlling the healthcare delivery system once people need health. But it is important to remember that we talk about unhealthy problems as if we can't do anything about it, right? The obesity epidemic. Well, there may be an obesity epidemic, but if you take a look around, you'll notice that, say, in Palm Beach, it might be a little bit less than it is in some poor neighborhoods of Miami. Or you take a look at the Obamas in the White House, black people from the south side of Chicago, and they're not fat. Why is that? Should we do a little blood test of the Obamas? Maybe Michelle Obama's arms are that way because of a genetic propensity to being buff? Or does it have to do with education and exercise and a lot of other factors? So that's tremendously important, but it's not what we're talking about this afternoon. So the fight back strategy number 2. As you heard Jason say, I used to be a journalist, so I have a propensity to try to speak plainly and boil things down. So there are 3 and only 3 ways to control the total cost of any good or service. 3 ways. Econ 101. The first way is you pay less per unit, right? So you beat up doctors and you pay them less and you pay the hospitals less and you just keep all your prices down. And that can work for a while if you have the market power to do that. The problem is that if you beat up docs too badly, they may stop taking your patients. This is why the SGR never goes into effect for Medicare. Because if you did, you wouldn't have any Medicare access for old people, and that would be a crisis for congressional people. And so one day I'm thinking the SGR will get to 125%, right? That if it goes into effect, every doctor in America is going to have to send a check to the government every week. And then Congress will put it off for a year and put it off for a year. I'm thinking, how high can we make the SGR? So you just can't pay less. Well, the other thing you can do is do less, right? If you can't pay less per unit to control total costs, you simply use fewer units, right? So you don't cover things. Now you try to be nice about not doing less. So maybe you put people in a managed care program. And you call it managed care, but what you really mean is managed cost. And you don't cover some things. Or you do cover some things, but it requires 10 phone calls and 3 letters to actually get somebody to pay. But the problem with doing less is that rationing doesn't really work in America. We are a nation founded on abundance. And saying no isn't really in our natures. Doing less simply doesn't work, and frankly, sometimes, as we all know, it can be penny wise and pound foolish. You don't cover something, you get something more expensive the next day. So, Econ 101, if you can't pay less per unit, and if you can't do less, what can you do? You do things better. You're more effective and more efficient. You shift the curve. You give the same or better quality of care for the same or less money. That's where we need to go. We need to do things better. Value, not volume. We need to shift the curve. Let me talk about that for a moment. So, in terms of getting all stakeholders together to join together in simple harmony, I believe Governor Scott's quote here refers to how well he expects everybody to work together. But there's also the quote from President Reagan in regard to the Soviet Union. Trust, but verify. And that's where we're going in medicine. Not that we don't trust our doctor, hospital, health plan, or whomever. Trust, but verify. Just like we do in so many other aspects of life. We check things out, we shop, we ask friends, we poke, we prod. Trust but verify. So value-based purchasing, that is, buying on value, is bringing verification to trust. Now, this is from Michael Porter and Elizabeth Olmsted Teesberg, who are Harvard Business School professors, quite well known. And what's interesting about this is not only what they're saying, but that their article is published in the Journal of the American Medical Association, not a well-known business publication. What that tells you, and I'm trying to talk politics as well as specific policy kinds of details, is the American Medical Association understands that this system is broken and can't go any further. The most political of doctor organizations gets it. The best and the brightest at the IOM, the Institute of Medicine, get it. We have a consensus on how we need to change medicine. The devil is in the details. The problem is when you actually do it, there will be winners and there will be losers. Nobody, none of us certainly, thinks that we're below average. So any system that would take money away from me clearly is flawed. How can we implement this in real life? How can we bring value? Because the hurricane is coming. So these are my reality-based caveats. That, yes, it's nice to say that value for patients, but value has to be explicitly defined. When we talk about care delivery, let's just organize it around conditions of care. It's a lot easier to do that from the Harvard Business School than it is at the bedside. You know, it's really easy to say, let's do something, but doctors deal with ambiguity. And we need to be respectful. We always need to be respectful of clinical reality. When you have any sort of change, you need to help people change. You need to help the people who need to drive the change or the people who are in the trenches. And we must always remember to help the people in the trenches. And, of course, read the fine print of any health reform proposal. So I'm going to give you an example of what they did in Massachusetts. I was a consultant for a number of years to Blue Cross Blue Shield in Massachusetts, where their CEO, who was a quality of care crusader, said, I'm tired of paying for the wrong thing. I want you to develop an alternative contract, an alternative quality contract that pays people based on value, not on volume. And because he was the CEO, all the folks grumbled underneath, and they did it. And because Blue Cross was one of the largest payers in the state of Massachusetts, they got together a lot of the providers, among whom are some very powerful hospital and health systems. And they brought them into the process. And they designed what they called the alternative quality contract model, which is one of the models for what we now call ACOs, Accountable Care Organizations. And they said, look, this is how we're going to pay you. And we're going to ask you, you heard about integration, the doctors and the hospitals have to be paid as one group, not competing with each other. And we're going to tell you that if you take this contract, because at first it was voluntary, if you take this contract, over time, if you provide better care, you're going to do better than you would otherwise. Because you can't ask people to commit economic suicide. You can't have pie in the sky kind of things. You have to reward people for doing the right thing. And as you can see, they have specific goals with specific ways of doing it. I'm just going to give you a few of the slides. From W. Edwards Deming, the quality of care guru, in God we trust, all others bring data. Right? Because Massachusetts isn't Florida, but there's a little bit of politics that goes on in Massachusetts, you might have heard. And so they had some discussions with the governor's office, and they had some discussions with other people, and they had some specific goals: process, outcome, patient experience, all of those. Ambulatory, hospital, specific goals anchored in the medical literature, anchored in data, and the Blue Cross plan invested a lot of money in helping improve the data. Remember, part of this is a technical issue. You have to help people change. But the other part is economic and political. Do you have the guts to stay the course, and will you put down the money up front to change the healthcare system for the future? Specific goals, data-driven goals, collaborative, but collaborative only up to a point. It's a stewardship solution where all folks try to win. Pay for performance, again, this shows you quality and efficiency. Blue Cross of Massachusetts is driven not by do-gooderism, they're driven by the fact that their rates were going up and their customers were leaving, right? If your rates go up too high, customers leave. And not only that, if you're in Massachusetts, you're worried about businesses leaving. Maybe you're not worried about businesses leaving in Florida. Your economy is doing pretty well, but I suspect that folks can move to Georgia or the Carolinas or abroad or simply not expand. So a little bit of idealism and a little bit of bottom line realism and a lot of work. Let's do this in the right way. So clarity, partnership, urgency, you can see the slide there, what they did, and a political subtext. What's the politics of your state? What's the economics? People know people, right? This isn't done in a vacuum. This is done sitting down with people and saying, listen, this is the way it's going to be. And in Massachusetts, they didn't start off with the 500-pound gorilla. There's a system out of Boston you may have heard of that's called Harvard. And the folks at Harvard, you heard before that money doesn't equal quality. It turns out if you're the Harvard system, everything you do is the best because you're the Harvard system. Well, somehow during the course of this contract being rolled out, a story appeared in the Boston paper about how the care at the Harvard system, partners, was paid for at a rate about 25% more than anybody else got. And yet all the quality of care indicators showed that they were no better than other big hospitals. It turned out that just having the Harvard name did not mean that you could throw away your crutches and leave the hospital alive. And so after a while, the folks at Harvard, a little bit of newspaper publicity, a little bit of inquiry from the state legislature and the governor's office and the state attorney general, a little bit of negotiation, decided that they wanted to be a quality provider also. They wanted to provide their services based on volume, not just fee for service. That's what we're talking about. We're talking about a long battle in the trenches to change your local healthcare system for the better with $59 or more billion at stake. I looked on the internet, and I believe this is what Florida looks like pretty much every day in the evening. This did come from the Chamber of Commerce, but I'm sure that was not a biased source. So, what's in your favor? The wind is at your back. The Affordable Care Act has gotten a lot of publicity for how it covers uninsured people and for Medicaid expansion. The other stuff is the really good stuff. And the other stuff, by the way, is things that policy wonks, Republican and Democrat, have been talking about for years. I was active in the Obama campaign in 2008, and I remember debating Senator McCain's healthcare advisor. And afterwards, I said to him, I don't know who's going to win this election, but except for covering the uninsured, most of what you say you want and most of what Obama says he wants are pretty much the same. Value, not volume, trying to drive our healthcare system towards some economic common sense. A lot of that is going on the federal level, and you can take advantage of that. There's a lot of change. People are scared. You can take advantage of that. We're at a period of turmoil, and that gives you the chance to have fundamental change. Again, this is a very recent survey of physicians by United Health. Doctors see significant opportunities to reduce costs. You have a unique opportunity to partner with physicians. Again, nothing is easy, but this is the chance to partner in a responsible way to drive change. Because you know what, doctor? If we don't shift the curve, then what's going to happen is we're simply going to pay you less or we're going to give you more bureaucracy. The alternative to economic sanity is not business as usual. It's regulation, legislation. It's not cooperation. It's confrontation. That's what we face. Are we going to have confrontation or are we going to have collaboration? Even tough love collaboration. This is also interesting. Again, the data showing bundled payment. That's the kind of thing they're doing at Massachusetts. That's the kind of thing that accountable care organizations do. Bundled payment is going to help the costs. All those other little things that people like to talk about. We're going to have retail clinics. We're going to reform malpractice. We're going to have people only use health care on days of the week that have a T in them. None of that stuff does anything much. They're all cute little ideas. All that works is bundle people together, integrated, coordinated care, and pay people for outcomes. That's what works. The other stuff is fun. It's peripheral. Employers are a big part of the picture. You start to change the benefit package. Not simply co-pays and deductibles, which is cost shifting, but value. You design the benefits so that people understand that they need to get value for their healthcare dollar. And by the way, you give them tools. You give them good tools. The good thing about the employer community is you and the employer community are in some ways immune to political pressure. You can act without worrying about a campaign contribution. Now, it may be that you're uninvited from going to the hospital charity ball. That's true. It may be that you go home and you have a terrible fight with your spouse because you can't go out to the hospital charity ball. But you have the clout to act economically for your community and for your business and put in this kind of change. So what are the barriers? Well, the barriers are that it's great to put up all those charts, but not everybody is suffering and not everybody thinks they're suffering. And in fact, one man's waste is another man's income. That's why you have to be careful about crisis talk. Whose crisis is it, anyway? Ask yourself that. The technology, well, we have the information technology to measure and manage healthcare, but the public and a lot of other folks believe that the technology that counts is the high technology that I can get at my hospital. If you hurt yourself playing tennis, you may deserve an X-ray, but I deserve an MRI. You just have tennis elbow. I may deserve multiple MRIs because you never know. And so the public believes that lack of technology is bad quality care. All of those of us who are in healthcare, my guess is the closer you are to the healthcare system, the more you know about the healthcare system, the more you try to avoid it, right? Those of us who work in the system, are not running to get surgery. And lastly, there's a culture. There's a popularity of panaceas. And that's really the cultural and political problem that we face. If I just put in a high deductible health plan, everything will be okay. Single payer will solve everything. There's wellness initiatives. If nobody got sick, healthcare costs would go down. Very true. There's panaceas. Panaceas aren't going to work. We know what to do. We know how to do it. Will we do it? Will we act? So I want to conclude with this slide. I actually have one more slide. It's a call to action, but this I want to talk about for a moment. I hate the term healthcare reform. It's meaningless. What I love about this is it says a reform is a correction of abuses, a revolution is a transfer of power. We are in a revolutionary period where we are taking power away from the providers to do whatever they want and saying, no, you're going to be held accountable. We're taking power away from health plans. Don't worry, I know what I'm doing, and the employers are holding them accountable. Frankly, although we don't say this out loud, we are taking power away in some ways from the individual patient. No, your insurance card does not entitle you to get whatever you want, whenever you want, for the most expensive kinds of things you're going to have to pay attention to. You're going to be accountable. We are taking power away from people. We are redistributing power. We are changing the balance of autonomy and accountability. And that is tough. That is revolutionary. That is difficult because nobody likes to lose power. Nobody likes to lose autonomy. And yet the better balance of autonomy and accountability will give us better health care, better quality of life, and an economy that is sustainable for the quality of life in this country. That's the revolution we're asking folks to fight. So, this is from Le Petit Prince. As for the future, your task is not to foresee but to enable it. Since I spoke to the folks at AIF, I've been really excited to come down here. Because this is a meeting of people who understand in the trenches reality. You are folks who understand how healthcare really works in the trenches, how economics works in a business, how the political system really works. You are the people who can make change. You are the people who know how to make change. And I suspect you are also folks who want to leave a legacy, who want to make change because you know how important it is. What we're talking about is inevitably a destruction of some of the old ways of doing business. And destruction of the old ways inevitably brings anxiety. But destruction often precedes renewal. And I believe that is the case here. And it is in that renewal that you can contribute to that the future of American medicine lies. Thank you very much. Questions?